evening, everybody, or morning or afternoon if you're watching this in the future. I sincerely want to thank everyone who's on tonight. I'm sure, like all of you, you've had, oh, hi, Pam's on there too, so I came up. I'm sure all of you or many of you have had a long day and you're either just in your offices or you're home in your jammies. But I am absolutely excited to give this specific webinar because I believe this is my first one on just a QuickSleeper. Is that right? I think it is. It's QuickSleeper alone.
It is. Yeah, it is.
Great. I have used a lot of technology in my office in the last 23 years, and I'm someone that brings in a lot of technology, and I like toys, but I will tell you that my experience, just in general, with the intraosseous method of delivering local anesthesia that we're going to discuss tonight has been one of the most profound changes in how I practice dentistry. And I don't say that lightly. You know, I would say digital x-ray and having the ability to give intraosseous anesthesia really are two of the watershed moments for me. And that's why I'm super excited about giving these webinars. One other thing is, I think it's important to talk about as a KOL, we'll mention this a little bit later, but I want to say it from the beginning, myself, Brian Richards, who's on, we do not make any money from the sales of these devices whatsoever. So if you decide to buy one, Anesleeper One or QuickSleeper, I don't get like a royalty check from NewSmile. But what I do get from teaching these is a greater understanding myself of how these devices work, and I have the ability to help my fellow pediatric dentists. So I'm really glad everyone's here tonight, and let's get rolling. And then I know some people, if you have questions, you can put them in chat. I'm very reachable. You're going to get my contact information. So if you tune in tonight and you have questions, put them in the chat, correct? Or you'll get my contact info. I'm super reachable. You can text me, Facebook, call. And then also I always make available, and I know Brian does the same thing, if you want to talk to one of us that uses these on a daily basis, we're happy to talk to you directly, okay? So here we go. Welcome. I am so excited that QuickSleeper is now to market. I will tell you that this was not easy for NewSmile to bring in the United States. We are now the QuickSleeper 5. So one of the things that's important to know, I think, with technology is this isn't a new device. This is now number 5, which means there were 4 versions of this before, but it took a long time to get this into the hands of the United States, and a lot of money and a lot of testing and a lot of blood, sweat, and tears. And so I'm very grateful for NewSmile to bring these in the US, because as Chris knows, it's not easy to bring new medical devices into the United States. It's very costly. It's very time consuming. And to have the market share that these devices have and the adoption rate of pediatric dentistry is unprecedented. So thank you. So a little bit about me, for those of you who don't know me, my name is Josh Solomon. I'm a 2nd generation pediatric dentist. So I've been in practice in California for about 23 years. So I was a spoiled Nepo baby, and I took over the practice from my father and was able to really grow things since then. So I spend about 70% of my time just seeing patients on a daily basis, and the other portion of my time is teaching. So I have my own learning center here in California, but I also travel and I do webinars like this. And I truly love pediatric dentistry. I'm very grateful for the life that I have, that pediatric dentistry has given me. And my goal is any device, any product, a new composite, anything that I think will help the specialty of pediatric dentistry, I want to get my hands on it and then vet it and disseminate it to all of you. And that's very important to me, and it continues to be something I do on a daily basis. So just a little bit about my office there. I came in, moved into the new facility about 2.5 years ago. A bunch of you that are on tonight have trained with me. So I run, besides my office, the BioClear Teaching Center in California. And about once a month, we're teaching hands-on courses. Anytime I have a hands-on course, we will include lots of stuff with intraosseous anesthesia. Anything that I teach restorative, I integrate intraosseous delivery of local anesthesia to every single one of my courses. So my contact information is here, joshua@pediatricdds.com. Website's here. And then if you scan that QR code, you'll also get all my contact information. If you go on my Facebook page, I have a roaming list of all my webinars. I'm usually doing quite a few each month. So please reach out to me if you have any questions about the devices tonight. If you have questions about anything New Smile related, I use pretty much everything New Smile makes. I just integrated their cement in my office and it is amazing. I have ditched all my other cement. I could go and talk about it for 10 minutes, but we got to talk about this. But if you have not tried it, I would highly recommend. They've got the price where it's very reasonable, and I'm using it for everything now, and I love it. And I don't want to get off tangents, but it's definitely something I would try. Okay. If you reach out to me, I don't get back to you right away, please ping me again. I will reach you. So it's my office. I'm in about 6,000 square feet, and I wanted everything kind of be open and bright and really comfortable for all ages because I do treat a lot of older teens and some young adults, and once in a while I'll treat a prosthodontist here or there. And then when we teach courses, what we do is we transform everything into the learning center. So all 13 of the 14 of the operatories we make in these flat benches, and everything's very hands-on. So if you want to train, we'd love to see you at any time. But tonight we are going to talk about really what I'd like to do to get an idea of the audience is we're going to run a poll here, and I'd like to know if you have experience with any of these devices. So Chris will run that for us. Thank you so much.
That
Chris,
poll should be live. Yep.
So number one, do you already have one of these devices, the SOAN and Sleeper One? And then number two, are you familiar with the QuickSleeper? And then number three, your preferred delivery of anesthesia. It's either a block, infiltration, a PDL, intraosseous, or other. And we'll let this run just for a minute here, and if everyone could hop on and click a button, it really allows me to tailor tonight's presentation. Good. So there's some people a bunch of people that are new to the devices altogether.
Yeah, it looks like it's a good mix.
Great mix. Great. So just so everyone knows, we're not really going to discuss the SOAN and Sleeper One tonight because we have tons of webinars on that. So this is really specifically going to be about the QuickSleeper One. I think that's it for the end of our poll. Good. Okay. So we have a mix of people. So that's great. Thank you very much for doing that. Oops, I messed things up.
Thanks, everybody.
I messed up your poll. Okay.
You messed it up.
I think, we're good. There we go. All right. If you didn't already know this, it's been my birthday for the last month and a half. Not my actual birthday. I'm not 50 yet, but it is my intraosseous birthday. So 2 years ago, I got introduced to the SOAN and Sleeper One, and I harassed Chris and all the other people at New Smile because I got so excited about it. It's all I wanted to talk about. And things haven't changed for all this time. I really have profoundly changed the way that I deliver restorative dentistry in my practice. I used to do a lot of a lot of conscious sedation. I have a parental permit, so I can give IV, IM, intranasal, all that good stuff. And I have almost taken the amount of conscious sedation that I perform down to zero. And I'm actually going to probably have to give up my sedation license at some point because I'm not doing enough cases. I will tell you that routinely I can treat a 2-year-old, a 3-year-old with extractions or any other invasive procedure, and local anesthesia is rarely an issue anymore. I will tell you that 9.8 out of 10 of my patients do not feel a thing when I'm giving. So we're not just talking about pain, we're talking about the sensation. Honestly, the worst thing is if they get a little bad taste in their mouth, and we'll talk about that tonight. So I feel like now having the QuickSleeper in my hands, I really have the trifecta of all the devices. So when I teach these things, I can really profoundly have everyone understand giving local anesthesia via the intraosseous route from 1 to 100 years of age. Okay. And we'll talk about the differences with the QuickSleeper. And then in August of last year, as soon as it became available, I got introduced to the QuickSleeper, and I don't think I put it down since. And I know Brian Richards is the same way. I will tell you that, just quick summary here, that the SOAN and Sleeper One are devices that are really designed for that patient who's 13 or 14 and under. Okay. So the business end, the needle on the QuickSleeper, the main difference is that's a very sophisticated piece of equipment. That's why the price is higher. But this will allow you to have that needle actually spin, and you can trephine through the bone and give local anesthesia via the intraosseous method to any age. Any age, doesn't matter if they're one, doesn't matter if they're 100. I do not struggle anymore like I did a little bit with Soy and Sleeper One, trying to get into certain areas with maybe that 11-year-old that's a little bigger boned. Don't have to worry about that anymore with a quick sleeper. It really is the Swiss Army knife of local anesthesia, and that's why I'm uber excited to talk about it. So I started with New Smile a long time ago, actually in my residency, because I went to UT Houston and New Smile was down the street. So I got introduced to New Smile very early on. And since then, I've been able to use, I believe, every single product on here pretty much. And since then, I've integrated all of these products in my office, everything from BioFlex to the space maintainers. So as I mentioned, if you do have any questions about any of these products, especially zirconia crowns, even for permanent teeth, I'm happy to talk to you about that. Went to Mexico last year to talk to the pediatricians there about them. I think they're really underused, but I really would love everyone to try the cement. It is absolutely phenomenal. It really is. So if you have questions about any of these things, please reach out, let me know. And if I don't have the answer, I will get you the answer. Okay. So as I mentioned earlier, as an educator and a trainer, I don't get a kickback in any of these devices. And that actually should say I do not. So I am so dedicated to teaching these. I am not getting paid anything for tonight, so this is volunteer. I don't feel like I can go on IPEDO and tell people go buy things if I'm making money off it. So as far as devices go, and so I'm completely volunteer. I don't even get like a turkey sandwich or something delivered in my office. So this is all on me, on my time, and it's just because this has sincerely, profoundly changed the way I practice, and I would love to get these in the hands of all my other fellow pediatric dentists. So thank you for allowing me to do that tonight. This is a great quote. Anesthesia is at the heart of the relationship that you establish with your patient. The clinical silence obtained ensures their confidence and cooperation. I never realized how much crying and that fear affected not my patient. That I've always understood. But one of the things that I've gleaned from using these devices for so long is how stressful it is for our teams. Being an assistant as a pediatric in a pediatric dental office is not easy, right? They're having to deal with me and any of my, mood swings for the day because things aren't going right, and they've got to treat patients. And sometimes the parents aren't nice to them, and they get, patient problems. It's a hard job. And when we have that child that is just struggling and crying and the parent's upset, that really weighs on you. It truly does. And having that ability to profoundly numb my patient without them even feeling the needle stick is a gift to dentistry, and I'm very grateful, and that's why I'm so excited to teach these devices. So dentistry used to look like this, and right, you had the sometimes a pedal that you would pump, or this was electronic, and you had a rope that would go all around, and this is how they did dentistry, actually without gloves. I talked to my dad about that when they just started using gloves when he started dentistry, and he had a pulse ox machine that was like the size of the room, but this is how things used to be. And then we had x-rays. I don't want to know how much juice is coming from this thing. It's probably not the safest in the world. I like his bib there. It's probably just a little smock. There's probably a ton of radiation coming from that thing. I don't know what all the gauges are. And then, of course, what we have today, right? And not only the x-ray equipment, but we have AI caries detection. We've got scanners, dentistry. Even from 10 years ago, I'm doing things very, very differently. So if we look at the way that we delivered local anesthesia, back here in, the 1900s, the only difference of what we use today is the business end, the needles there, those were hand sharpened, but nothing has changed, right? And that's when you think about all the evolution you've had with your equipment in your office. I mean, there was a time when I went into the dark room and had chemicals and had to open up the things and I don't even remember anymore, right? But local anesthesia is one of those things where it really has not changed. And I like this analogy of a light switch, okay? So when I'm restoring teeth, when I'm treating that patient, I want my local anesthetic to be the secondary thing. I just want it to be the thing that I need to do to get done with, to get into the restorative dentistry. But as we know as pediatric dentists, this often becomes not only our patient's biggest worry and issue, but also our parents. And we know that if those parents at the beginning of the appointment are already holding onto the door and they're shaking, they often translate that to their children, right? So there's a whole idea of a light switch. So when I go home tonight and I go to my bedroom, I don't have to guess where the light switch is, right? I could have my eyes closed, I could walk in, I know exactly where it is. And I don't have to worry about the light switch shocking me, right? And I know 100% of the time I hit that light switch and the lights above my bed just shut off. I don't have to think about it. I don't have to worry, well, if I touch a light switch here, is the light down the hall going to go on? Well, maybe sometimes or sometimes not. It just is a rote behavior, click a button, and then you move on. And that's what I want for local anesthesia. I don't want to give a block and realize that patient's not numb. I don't want to have to give multiple injections to a patient and then go back and realize, well, they're still feeling things, right? It needs to be prescriptive and it needs to be predictive. And that ability we have with delivering local anesthetic like this. And, not only for our patients, right, that they have the fear and the pain. With general dentists, they don't have to worry about, well, if that child's uncooperative or that patient's uncooperative, they're going to cancel that hour appointment, right? I'm sure everybody on tonight would agree that dentistry's gotten less profitable than it was 10 years ago. To be honest, it really has, right? Insurance reimbursed some practices. Insurance reimbursements have decreased. Overheads have increased greatly. And just having that one restorative patient a day, or even every other day, that you've scheduled for 45, 50 minutes an hour, and the patient can't get through that appointment, times that by 10, times that by 18, that adds up quite a bit. And just that alone will pay for one of these devices for itself over time. And that's not even the internal marketing from that patient and the parent loving you. It's not only your own peace of mind knowing that you can deliver anesthetic and it's going to work and it's not going to hurt the patient. So having this predictive method of delivering anesthesia is important to me for patients of all age, because when I had my SoAnesSleeper one, I love it. I still use it. But for me, when I teach this, I usually say 13 and under, I'm pretty much 100% of the time, I can use a SoAnesSleeper one. I can use a 9mm needle with pressure and push through that cortical plate. Patients 13, 14 and above, not always possible. Yes, if it's a small statured patient, and even if they're 30, sometimes you can get through with a 9mm, but it's not just getting through the bone. It's also having the length of the needle, and that's one of the things we're going to talk about tonight. So you look at a dental chair 80 years ago, right? And today, very different. But one of the big problems that we have as pediatric dentists is time, correct? Because I may see 30, 40, 50, 60 patients a day, and every time if I give a block and it fails, or that patient's not numb, or I have to time, I give a block and then I have to go away and I have to come back. All these things are costly for us, right? All these things are costly. And having that loss of time, it really adds up over time. So one practice piece of management advice I have for all of you is, if you haven't done time studies in your office for yourself, or especially associates, grab a piece of paper and every single day, especially if it's someone, a new practitioner in your office, time how long it takes for them to do force sealants, to do that AMOB deal. And what you're going to usually see is a lot of times we're booking too long or booking not long enough. And this adds up over time. And then if we're having issues with local anesthesia, that adds to that problem, right? So not only is sometimes time an issue, but being able to control that patient with a long syringe, and you won't notice this until you use one of these devices, the relationship you have with the patient is very different, because when I'm giving local anesthesia intraosseously, no matter what the device is. I still practice this Larry Johnson circle of safety. I have that patient sitting very close to me because the unit is delivering the anesthetic without me having to put hand pressure. So I don't need to be farther away. That patient can sit closer to me, and I really can control the movement of that patient much more safely, okay? One of the most important things I'm going to show you tonight, and if you have a So In a Sleeper one, you already know this, is we don't have to worry about collateral numbness with the intraosseous technique. So when we give a block, the way I describe it is if you want to numb a finger, you can do a digital block right here at the end of the finger, or you can give it at the elbow. You can numb a hand at the end of the elbow, no problem. But what's going to happen? All this other anatomy that doesn't really matter is also going to get numb. And we don't have that issue with intraosseous local anesthesia. If I'm going to numb one area, just that area is numb. When you think about when you're giving a block, we're giving it blindly, right? We're just giving a larger bolus of local where we think that the nerve enters, and we need to wait for that local to then perfuse through cortical plate or in that medullary space and get to the nerve. We're actually giving far more local anesthetic, especially with a block, than we do with the intraosseous method, because with IO local, I'm giving just next to the teeth that I need to have numb, and that's all. So the amount of local anesthetic I'm using is far, far lower than it was before. And I'm sure all of us, if you practice long enough, you had that call from the parent in the ER saying, well, we're at the emergency room, Dr. Solomon, and I'm here with the patient. And mom seems pretty upset because you injected a drug that they're allergic to. Mom has a sulfa allergy or something, and they think that, your patient is allergic and now they have a swollen lip. And we've given them Benadryl and Decadron, and I've had this happen to me twice. And then I have to say, no, they bit their lip, right? When I administer local anesthesia in my office, and I have only used a standard syringe maybe a handful of times during general anesthesia, and that's all. I don't even know where they are in the office anymore. I just don't even know where they are. No one gives one to me. It would be completely foreign to me to give a block or to give local with a patient that's awake. We just don't use it anymore. But I have zero collateral numbness if I practice. So that means every patient before lunch, as long as I'm not, doing something surgically and I need them to not, maybe chew because they're going to pop a suture, I'm worried about hemostasis, go ahead and eat. Yep, go for it, right? And parents all the time, their eyes pop. What do you mean they don't have to wait, right? Nope, they don't have to wait. Their lip's not numb. Go ahead. And that alone makes a big difference. I never realized how much, even intraoperatively, when I would give a block, how much that collateral numbness affected the patient, right? Because we see those children, right, that we give a block to and they're fine for a little bit, and you get your rubber dam, you isolate on, and they're having a problem right away, and you say, Mom, I didn't do anything yet, right? They're feeling their lip and they're feeling their tongue. And that alone, not having to deal with that anymore is a big game changer, okay? We don't have to worry about loss of motor function, right? We don't have to worry about that droopy eye. We don't have to worry about the lip. And this is probably more apropos for adults, but it can be for our teens and our young adults. Stop it. It's doing weird stuff. Hang on. There we go. Right, this kind of thing. Is the volume working?
Unfortunately, yes. This is something that can happen.
Yeah.
It's something that happens when we're doing an inferior dental block. An inferior dental block is an injection that the mandibular is too much. The hardness wears off from the teeth.
Let's go to Silver. So funny, but not funny. I'll tell you one quick story. I had a patient that had a little bit of palsy like this afterwards. Mom was in tears, and I was, Mom, what's really going on? It's not that big of a deal. Well, Grandma had a stroke, and Mom, to her in her head, was thinking that the child had a stroke, the teenager, and really not a great situation. For us, yeah, we don't have a lot of patients that would be going back to work. I will tell you, for especially if I'm doing anterior composite work, not having to worry about a numb lip and that patient be able to move their lip is a big advantage. So we don't have to worry about this anymore, okay? And appointment management. So What happens in my office all the time is we will schedule, let's say that patient's scheduled for 40 minutes. And my assistant, we do a surgical kind of timeout, an operative timeout at the beginning. And I walk in the room and they'll say, okay, Dr. Josh, Susie's here. We're treating these lower teeth. But she's in a really good mood today. I noticed that we have some time after this, and I've already talked to mom, and mom said, if we get S&T done and Susie's doing okay, we can hop over to K&L. Now, I used to not do that because I don't like to give bilateral blocks. Don't have to worry about it anymore. So this whole idea of midline's gone, right? We're just numbing teeth. We don't have to worry about, half that quadrant with a block. Is you finish one quadrant, you can immediately go to the other quadrant, numb that, and go. Some people worry about, yes, the patients get numb right away. Is that an issue? No, I'll give local. And if I need to do a couple checks, I'll do a couple checks and then I'll go back. I don't necessarily say, okay, they're numb right away. I would say, I give local. I'm going to do a few things and come back. So you really have that flexibility in how that you schedule. I don't change my schedule because of giving intraosseous anesthesia. Some people have, but really where it makes a big difference, and this doesn't happen a lot for us, but you have that older patient, you gave a block, and of course it's always the one where you're running behind and then it doesn't work. I don't worry about that anymore because I'm giving that local anesthetic at the source. I'm giving it right by the apex of the tooth. I'm not worried about them getting numb. And we know that not only there's the interalveolar nerve, there are quite a few other accessory nerves. I had an 18-year-old. I could not get her numb no matter what. Mom said all the other dentists couldn't get her numb, so I sent her to the oral surgeon to have a CBCT, and it turned out that she had these very rare accessory nerve canals in a couple different places of her jaw. And once we knew that, I'd give her mylohyoid, I'd give her all these other, fancy injections, finally got her numb. But if this was intraosseous anesthesia, it does not matter. So you can have all these other accessory nerves going to that injection site in that area. It does not matter because we're delivering our local right at the apices of the teeth. So it's just not even an issue anymore, right? And it's usually that IA, and it does not matter, okay? Does not matter because my goal isn't to numb the inferior alveolar nerve. My goal is to only numb the tooth or the teeth that I'm delivering local anesthetic to, okay? So we don't have to talk about this anymore because all these nerves doesn't matter, right? What nerve do I care about? The nerves going to the teeth. That is all. That is all. And, that the block is definitely the most frequently used injection in dentistry. And I was thinking about this earlier today. I have no idea the last time that I gave a block. I mean, it had to be 2.5, years ago. And an older patient, that was August of last year. So it's completely foreign to me to give a block to a patient. And these can fail, right? They can fail and then you're running behind. And we see all these accessory nerve canals that are present for the lower arch, and these are all failure points, right? These are all failure points. So we don't have to worry about this stuff anymore, and we can move on. There's all these other nerves going there, and we don't have to worry about it. Okay, so what are the 3 devices to deliver local anesthesia? So those of you, there was probably about a third of you that are not familiar with these devices at all. I'm going to make it very simple. So on the 2 devices on the right are the devices that we've had for now 2.5 years or so, or a little bit more than that. Yep. And these are devices that are designed for, what was that, Chris?
No, I was going to say it's been about 3 years. Yeah.
3 years. Okay. Thank you. So I was probably 6 months behind the OGs of local anesthesia, like Ian Bynum, right? Or Eric Hans. So the 2 devices you see on the right are the devices that I've had in my office for, 2+ years now. So Sleeper 1 and SON. Both of these devices are designed for that patient in primary mixed dentition. And in my hands, I think what I typically like to teach is kind of 13 and under. Can you get an IO injection performed with one of these devices that patient's older? Yes, but reliably, I like to say 13 and under. And the reason being is if we look at the needles, we're most of the time using a 9mm needle for both these devices, and we were manually pushing through the cortical plate. So the problem is that patient gets older, that cortical plate becomes thicker, And it gets to be very, very difficult, if not impossible, to manually push a 9 millimeter needle through you're not going to get a 9 millimeter through my bone, right? So now the difference is that we have a device that will rotate and spin at, I think it's 12,000 RPM, and not only trephine through the bone, but it will also deliver that local anesthetic. Now, the important concept here is if you have a QuickSleeper 5, you can do all of the same things that the Sew-In and Sleeper 1 can do. So you can put a clear cartridge on here if you want, and a 9 millimeter needle, and it'll function exactly the same as these other two units. The cartridge is different, shaped a little differently, but if you want to use this for primary dentition and a 9 millimeter needle, great. It'll do all of the things. But it is the only device that is on the market that's FDA approved that will spin like this electronically and then deliver the local anesthetic. Many, many years ago, I used either the X-tip or one of those devices where you would put the needle on your slow speed and you would trephine, you drill through the bone, and you take that needle out and you put another device in and then you would inject. But this is an all-in-one delivery system. Okay, so if you were to purchase a QuickSleeper 5, you can do all the things that the others will do. Okay, so why does the delivery speed matter? Because I've heard people say, well, I can take a 9 millimeter needle and I do this during general anesthesia, and you can often put a standard 9 millimeter needle on a syringe and put it through the bone and deliver. The problem is delivery speed. Okay, so when we use the X-tip or one of those devices, and I think remember it hurting everybody, it's because when you manually push a local anesthetic through that syringe, you cannot deliver at the same speed that these devices do. They literally give that local anesthetic drop by drop by drop. And so why does that matter? Why does having electronic delivery matter? Because I've had some people say, well, can I just buy a X-tip for a few bucks per patient? So the issue is you need to, number one, give it slowly, give the local anesthetic slowly enough where the patient doesn't have pain. We know in the, when we get past the cortical plate and we're in the medullary space, the only nerves that are there are going to the teeth. Everything else, there's proprioceptive nerves, so they feel pressure. So if we give that injection through the bone and we use a manual syringe, that patient, I promise you, they will feel that pressure. If either three of your devices in the wrong mode and you give an intraosseous injection, they're going to feel the pressure if you're delivering it too fast. But more importantly, we need to give time to let this local anesthetic perfuse slowly, but also it's a vasoconstrictor. So if you give a local anesthetic too fast, you're going to perfuse, and too high of a pressure, you're going to perfuse that local in a much greater area. And if you give it too fast, that epinephrine does not have time to work. So yes, we want our local anesthetic to spread over quadrant, but we want it to be slow and we want it to be controlled. Because if you give it too fast and it spreads too quickly, you're not going to have profound local anesthetic. Okay, you may only get one tooth here, one tooth there. It's not predictable. So I need to be able to give in the quadrant and have it stay in that area long enough to anesthetize all the teeth and the bone and the soft tissue. So with electronic delivery, it's literally giving that local anesthetic drop by drop by drop. And it's allowing that patient not to feel the pressure, not to fire all those proprioceptive nerve endings, and also to let that local anesthetic numb the teeth, but as importantly, let that epinephrine close vessels down in order to coalesce and to marsupialize to keep that local anesthetic in just that small quadrant, right? We want a number of teeth numb, but I don't want that whole quadrant immediately numb, because the problem is we're not going to give enough local if it spreads out too quickly. Okay. The whole goal in all this is to have that patient profoundly numb in an area that is predictable. Okay. So when we look at the QuickSleeper, what are the differences? Obviously, you see that it's a cord, but also we know that the Sew-In is corded as well, right? But this is a very, very precise device. People ask, well, why is it more money? I'll tell you, there's a lot of very sophisticated electronics in this device, because not only does it have to deliver local anesthetic in certain modes electronically, so that motor has to be extremely precise. it has to constantly monitor the pressure. There are other units that I've seen on the market that say they can deliver local anesthesia. What you have to know is at least all the product information I've seen in all those devices do not say that it is FDA cleared for intraosseous delivery. And if it's me, I don't want to give a device that I got on eBay that you can also buy car parts and pickleball equipment from the same vendor that is selling my local anesthesia device. Okay. These are highly sophisticated digital pumps to give local anesthetic to children. So let's treat them as such. And you're gonna have to pay for it. But this is such an important part of how we do dentistry, right? So those are the 3 devices. The business end is the same. You can put a 9mm needle on all 3 devices. You can put a 16mm needle, that white needle. But vast majority of the time, so in Sleeper One, 99% of the time, I'm putting that green 9mm tip on. Now for QuickSleeper, routinely we're using a 16mm. Okay, you can put a 9 on there, no problem, but I would not try to rotate the 9mm needle. It's really not designed for that. If you're going to use a 9, just push it through the bone. 16 is really where rotating. And again, there's the 3 summary of the devices. If you're only going to buy one device and you don't mind spending a little extra money on it and you see that you have patients that are a little bit older, don't even think twice about it, buy a QuickSleeper. If you have a very young practice, your patients are 2, 3, 4, 5, I wouldn't buy a QuickSleeper yet. Okay, I would stick with a So in a Sleeper One. Now, if you're going to buy a second device, and your patients, and you're going to grow into your practice and, they're going to start getting older, I wouldn't even think twice I'd buy a QuickSleeper because yes, the price is a little bit more, but if you're already going to spend the money on a So in a Sleeper One, you might as well spend a little bit more and be able to do everything that the device does. Okay. So, the benefits are, and I went through a lot of these already, but I can tell you that if I focus on QuickSleeper here, I've been the guinea pig for my associates and a whole bunch of dentists that have come through here. So I don't want to admit, because I don't want to think about it, how many times I've been the guinea pig for injections in my office. And I will tell you that I have never once experienced pain with the QuickSleeper. The only thing that I have felt is a little bit of vibration, because when that needle spins, there is a little vibration with it. And I tell kids and teens, it's going to feel like a cell phone. Okay. So I would say I profoundly 8 out of 9 or 9 out of 10 patients don't feel a thing. I don't have to worry about collateral numbness. I don't have to give an accessory secondary injection on the lingual. Definitely fewer appointments, and it really works immediately. Now, dental, teeth-wise, it's going to work immediately. If you are going to do soft tissue surgery or really bear down with a rubber dam clamp, I will wait a little bit on the lingual side because that anesthetic does need to perfuse backwards now, right? If you're giving it in the bone, it's got to work through the plate going to the soft tissue. However, I will tell you that the profoundness of the local anesthesia that you get with a QuickSleeper is very different, and it comes down to the 16mm needle. What happens is our patients that are in this kind of tween years, they probably could use like a 12mm needle, right? We just don't have one. So with that 16mm needle, I can assure, especially if there's a fair amount of permanent teeth in that area, I'm truly getting down to the level where I need that needle to go. We know with teens, if you have a 14-year-old, yes, you can push a 9mm needle through the bone, but it's typically that needle's not long enough to truly get into the medullary space. You're likely just going to be delivering that anesthetic into the level of the bone. It's likely going to be just a interceptal local anesthesia, and you may get 2 teeth numb. That 14-year-old, that 15-year-old, that 16-year-old, I do it every single day now. I get 1 or 2 spins, boom, through the bone, and I am numb in that entire quadrant. When I've been given this injection a lot, let's say between 2 and 3, that's mostly where I've received. Typically 2 or usually 3 spins, I'm through. And even at a quarter carp of 2% Lido or 4% Septo with Epi, I am numb my entire soft palate. Back to my soft palate, half my palate, and typically profoundly numb up to lateral. We're talking everything, bone, teeth, it is numb, and the anesthetic is much more profound than I would get than just giving in the vestibule, okay? So I don't have to wait, patients don't hurt, nobody's stressed, everybody's happy, right? On the lower end tier, what would I do for a child here? Let's say with my QuickSleeper, I would just simply put a 9 millimeter needle on and give the injection there. And then I can go to my next patient who's 15. If I'm restoring 2, 3, 4, 5, which I do a lot of posterior composites for teens, and I give one injection, my rubber dam goes on. I don't have to numb every single tooth and then give a palatal, right? I could do it today, yesterday. I need to treat a whole quadrant of composites in the back. I'm giving one injection and they're profoundly numb. Rubber dam goes on and I'm treating 3, 4, 5 teeth at a time. So the goal here, right, is to get that needle down to the level of the bone. So I want to show you now the difference of this device. So this is the first step when we give our local anesthetic, right? So we're going to give this first stage 1, which is in the papilla. So now you're going to see the device for the first time. So this is a 16 millimeter needle, and we can give this a little bit more subgingival, and then you're going to see the rotation. This is a quicker video. We've got more later. And with that rotation, we're trephining that needle through the bone. So there's one spin, then the second spin, and then typically for most patients in my practice, and you'll see it slip through, 1, 2, and then we're delivering. So typically most teens, I find I'm through with 2 to 3 spins and that's it. Now for me as an adult, sometimes it takes a little bit longer, maybe 4 spins, 5 pins, but most of the time, I don't think I've gone past 4 rotations. And literally at this point, all that patient feels is a little bit of vibration. And especially with that 16 millimeter needle, there truly is no need for a supplemental or secondary injection. When you have the needle that is long enough and you're able to drill through that bone, trephine through that bone, and truly give in the medullary space with that 16 millimeter needle, I find the profoundness of my local anesthesia is much greater than even with my SoAnesthesia 1. It's not the device itself, it's the needle that makes the difference, okay? And for those of you who are new, basically the way we think about this is it's like the velvet rope of the nightclub, right? We can go straight past that bone. I'm not giving in the vestibule, having to wait to perfuse to the bone. I'm giving that injection in that medullary space, and then I'm going straight to the apex of the teeth. Okay, so when we give this now, many of you are not used to seeing that 16 millimeter needle, but here's the 3 stages. So first stage is in that periosteum. We're getting the soft tissue and the bone numb, and then we're going to switch positions, and then we step on our pedal and we're going to give our rotations, and then it's going to trephine through the bone. Now the diffusion, typically if I'm talking about SoAnesthesia 1, at this point, I'm discussing, well, maybe you only get 2 teeth. Not the case anymore. So if you have that 13, 14-year-old or that older patient, you are going to get definitely 2 teeth distal and 2 teeth mesial without an issue. If this is a 9 millimeter needle with the SoAnesthesia 1, you may only get 2 teeth, and sometimes it's even hard to get that if the needle's not long enough. And then on the lower arch, you're definitely going to get 1 tooth distal and you'll get a number of teeth mesial. But again, with a 16 millimeter needle, if you're truly getting down to the correct depth, you will have that spread much greater than you would with the SoAnesthesia 1. And we don't have to worry about this whole idea of quadrants anymore, or of the midline. We can numb that entire quadrant. And if you were to do so, and this isn't something a pediatric dentist would do very often, but 3 injections, you can numb the whole lower arch or the whole upper arch, right? So you give it midline and then in the 2 posterior quadrants, and everything is numb. Okay. And top 1, 2, 3. Again, I can't tell you the last time I've ever done this numb entire, I'm not doing it all on 4 taking out teeth, but if you want to, 3 injections, you can numb the entire upper arch. Okay. So I want to show you one more video here with a little fun music. So this is our first stage. We're about 15 degrees away from the bone, and we're going to give this drop by drop local anesthetic enough so the soft tissue and the cortical plate is numb. And this typically takes 6 to 8 seconds, sometimes 10 at the most. And if we stare at it, it takes longer. Now we're going to switch positions. You notice we're at about a 45-degree angle. The needle is just going to touch the bone. Then we're going to step on our pedal, and you're going to start seeing the first rotation. We do this in pulses. So there's 1 rotation. You see the needle spin. And we're telling the patient they're going to feel a little gentle vibration. There's 2. and there's 3, and they're going to give it a little bit more to confirm they're in. So we're not burying that full 16 millimeter needle. I want to show you one other video here. This is Brian, who's probably still on tonight, delivering to one teenage patient.
No, you can just see the
and you have to be smiling like that all the time. Okay, so here's our stage 1. And you do notice that we give this a little bit more apical than we would with the with a 9 millimeter needle, as we really want to ensure that we have that whole area known. So this is again 5-10 seconds or so. I would tell you it's a little daunting the first time you give an intraosseous injection, and it's even more daunting when you have a rotation. General dentists, they are working in the bone level much more than we do. Do you see that little movement that he did to get the rest of the local off his needle? Chip, that's an important step. So here we go.
A little bit of buzzing here, Jacob.
See, you said same thing. A little bit of vibration, a little bit of buzzing. Here comes 1 rotation, 2 rotation, boom. He's already through right there. And then 1 for good luck. All right, so that's 3 rotations, probably 2.5. And now that needle, we're burying it about 2/3, and we are truly at almost the level of the apex of the tooth. This is how you get this whole quadrant on an older patient that's in permanent dentition numb. It's really that easy. I will tell you that for us as pediatric dentists, it's much easier to train these devices, because if you have adults that have thick bone that are bruxers, sometimes it does take 6, 7, 8 rotations to get through. That's normal. The most rotations I've ever had for any of my patients is, I think, probably 4. And we're not having to struggle like with the 9 millimeter needle where you're doing hand rotations. I don't stress about this like I would a little bit sometimes with the QuickSleeper 1 if they were kind of mixed dentition, or if it was in a canine area. I didn't know if I was going to get it through. I just don't have that worry anymore, because I could literally put this needle anywhere in their mandible, anywhere in their maxilla. I'm going to step on the pedal. I'm going to give it 2-3 rotations and through. So the stress level for me really goes down. I want to show you one other example here. It's going to be the same every time, but that little guard you see near the end of the needle is just going to protect the lip. So we're giving that stage 1. And it's giving drop by drop. We're going to switch positions, and then we have to learn how to speak French. Okay. And we're just barely resting that needle on the bone. And then you're going to see the rotation here. So we're switching buttons on our pedal, 40, 45 degrees. And you'll see the rotation, and it's 1. You saw the D rotate, 2, 3, and this one maybe a 4. 4, boom, and they're in. Okay, so we don't feel the pop anymore because it's rotating through, and it truly is that easy. I just, we don't talk about trigonum here, but if you do, there are some pediatric dentists that do take out a fair amount of permanent teeth. You can get through thicker bone. It's in the back. You would never be able to, this would be pretty hard to do with just a 9 millimeter needle, okay? For those pediatric dentists that take out permanent teeth, especially hot permanent teeth, you have that infected molar. I will tell you, having the ability to truly get that 16 millimeter needle and get it really down to the apex of a permanent tooth, especially if that's an infected tooth, makes all the difference in the world, okay? There's really no injection that you cannot give with this, okay? And really it comes down to one of the big things is the needle itself. Now the shape of the needle is the same for that 9 millimeter green as it is for the white. This is a 3 bevel needle. And so it allows us to press through the tissue. And one of my favorite party tricks I do when I'm speaking is I'll take either a 16 or a 9 and I can put them in my hand all day. And I promise you, I will not feel that injection, okay? And so that's this. I really want to focus on the 16 now. Can you use the 9? Absolutely. I don't rotate with the 9. The 9 is for manual bone penetration. You can put it on the end of your your QuickSleeper, either with the metal or with the clear cartridge, and just push through the bone for younger patients. But vast majority of the time, if I'm using this, I'm using the 16. And this is what we get with this electronic delivery. It is literally drop by drop by drop. Okay. And you really want to make sure that if you're, new to any of these devices, you have everything set up correctly as far as the settings. If you buy a device, doesn't matter, all three of them, they will come with training. So they don't just give you the thing and say, good luck to you. There is onboarding that is mandatory. Not only with the mandatory onboarding training, with the QuickSleeper and Sleeper One specifically right now, and I think we're adding KOLs all the time. If you have a question, you have a problem, you're going to get either myself or Brian Richards, and that list of people are expanding. And if you need help, we'll get on Zoom with you. There's more help than you need. So I don't want you to ever feel that you're going to buy one of these and not get help. Trust me, there's more help than you'd ever want or need. On our Facebook group, for those of you that are joined, if not, I would highly suggest joining. People actually fight to answer questions quickly because everybody wants to help here, okay? The pedal, for those of you familiar with Sew-In Sleeper One, the buttons are opposite. So that's one thing you do want to be careful of if you get one of these, is that small pedal is no longer the drop by drop. That is for the rotation. So you do want to make sure that you pay attention to that. There's only one pedal to give the local anesthetic. And so what happens is the unit's smart enough. If you're stepping on the big pedal, it'll know initially to give drop by drop. And then when you click on the needle rotation and then you go back to the large pedal, it'll know to just give that in cruise or drive, however you have it. But we often get that question. That's how you know. Could you give a standard block with one of these? I don't know why, but you can. And this has that, you can change the speed on these, although I changed no settings on these whatsoever. It comes with instructions just like this out of the box. And as I mentioned, I think it's important, I recently went through this one thing I did not mention. I had a 15 or 16-year-old filling, and it was deep, and it went south on me. It was 15, I think, MO, and I was just before the CSPD, and I had to have endo on a posterior tooth, first time for that. And let me tell you how many injections I got. I think I stopped counting at like 8 for one tooth, because he gave local and he gave local, then he gave palatal, and then he gave a PDL all around the tooth. And if this was QuickSleeper, it would have been one injection. That's it. One injection, it would have been numb for at least that hour. And when I've gotten these devices, this is my summary. Number one, it sucks getting multiple injections. Doesn't matter what the arch is, but I was sore afterwards. Every time you go in with that needle, you are sore. But when I've had this on myself, the only thing that I was reminded is septo is absolutely disgusting. It is one of the worst tasting things ever. So it's just a reminder, please have that suction. Doesn't matter what of these devices you're using, please have that suction out. And I think I've got a slide here as far as using one of the spiffies. This is the same mantra that I use. Doesn't matter what the injection device is. It's either Sew-In, Sleeper One, or QuickSleeper. These are my mantras. So number one is the power on, right? Number two, these are the 4 P's. So it's power, and then plan where I'm going to give my local, which local I'm going to use. We're not going to get into that tonight. We talk about in all these webinars. And do I have the correct needle on? Have I looked at my radiograph? Then I want to make sure my pedal's in the right position. The last thing you want to do is go ahead and try to give that stage 1 and realize there's no pedal underneath you. I also test, this is actually not an issue for the QuickSleeper because the little box, the brain, is sitting away from that patient. But for Sew-In, I definitely will test it ahead of time, because if your pedal's under the chair, sometimes that can interfere. And then I want to make sure my positioning is correct, okay? So we're going to look at our radiographs. Doesn't matter the device. We want to make sure that we have some room between the roots, and that we're not injecting into a site of infection. And we're going to look at a radiograph every single time. Someone sent me a message earlier tonight about, well, what happens on the lower anterior? You give one injection. Doesn't matter if it's permanent teeth. Doesn't matter if it is primary teeth. You're going to give one injection midline. I do a fair amount of cosmetic dentistry pre-post ortho with direct composites in the anterior, and it's very nice to give one injection in the bone, and then I know from canine to canine they are profoundly numb. I don't have to give multiple injections. The other big thing is I don't want multiple bleeding points in the sites where I'm going to place composite, because that's always been an issue, especially if I didn't have a rubber dam on for that patient. As far as the anesthetic choices that we use, it's going to be the same for QuickSleeper, Sleeper One, or Sew-In. Vast majority of the time, we're going to use 1 to 200,000. epinephrine with our 4% Septicane or Articaine. Okay, you can use the 1 to 100,000, although really the only time I would do that if I was worried about a highly infected tooth and I was only treating one tooth at a time, or if I wanted to lengthen the amount of time that patient's numb. So I find for me, it's definitely more than an hour, depending on which local anesthetic we're using. But it doesn't matter, QuickSleeper, Sleeper One, or SOAN, your choices are going to be the same. And I want to talk about 1 to 50 on our lidocaine. Oh, this is one of the key things I would love for everybody to take home tonight. Not physically take one home. You can order your own on Amazon, but we have a spiffy at every single operative station now. So prior to using any of these devices, we have that spiffy out. These are just xylitol wipes, and they're disgustingly sweet, and we know xylitol is a natural sugar. So what I will do, even prior to giving the injection on a child that I'm a little worried on how they're going to do if they're taste sensitive, I will take that spiffy and I will wipe off their tongue ahead of time. It does two things. One, I've already loaded the sensory there on their taste buds, and number two, gives them something to think about when they're getting the injection. But Septo is disgusting. If you have not tasted Septo anytime soon, go back to your offices tomorrow, put 1 or 2 drops of Septo in your mouth, and you will, trust me, you will make sure that suction is right next to your patient. But these are really nice to have available for you, okay? You know, as far as the amount of local that we're going to give, with the QuickSleeper, it's not really going to make a difference if it's Sleeper One or SOAN. Most of the time, I'm giving about a half. Now, if it's an older patient, often that I'm using my QuickSleeper for in a 16 millimeter needle, I'm usually giving about 3/4 to a carp, depending on how many teeth that I'm giving, or I need to have numb at that time. Okay, so definitely we can say that our anesthetic now is definitely evolved. This is what the whole package looks like. There's the little brain box and it's a USB. People ask, can you move this? Yes, you can move it. We move ours all day. It is a plug-in, so you have to plug it into your operatory, but it's very easy to move around. It's literally the pedal and a wire in a little box and the power, and that's all. So very easy to move between your operatories, unless you want to buy multiple ones. I've got a large 6,000 square foot office, and I've got one of them, and we move it around. Not a big deal whatsoever, okay? And really, for me, I just don't even have to worry about patients at all. And that's what I want to leave you with is I'm not worried about age. I'm not worried about can I manually push through the bone. I've got one unit for that patient who's 1 or they're 100, and I can effectively numb them every single time. Okay? And we're right on time. Operating costs, just really quickly. Yeah, you got to buy the thing. And then these needles are, I believe, 27 cents. Standard needles, probably 20. So for me, for all the advantages, I don't mind paying a couple more cents just for the needle. You cry once, buy once, right? You buy it and that's it. And the operating costs are essentially, a few cents more for the needles. But for all the advantages that we talked to tonight, for me in my hands, it's worth it. Okay. You have to imagine, you're paying already $6 to $7 grand for a sensor. So these are about in line of what, a sensor would be in the practice. And, I'm fine with my SOAN or Sleeper One on adults. Well, this is, you cannot reliably use your SOAN or your Sleeper One with adults or with that 14, 15, 16-year-old patient. Okay. I want to show you one more example before we close out here. Right, here's what it looks like, the upper. So we're going to give that stage 1. You can see we've got pretty profound blanching there at that papilla. We're holding our suction close. Probably a little bit more of that stage 1 than I would give.
Here's a little bit of buzzing here. Okay?
Actually, no, that's appropriate. Yeah, no, that was about 8 seconds. I'd say that's actually great. Here we go. A little bit of buzzing in here, Brian. There's the buzzing. So you're going to see the rotation. 1, 2. That's literally what it sounds like. 3, you see the pumping action there? And now he's in. Okay. You will find that the rate this delivers is much faster in general than SOAN Sleeper One, and it's just because you're truly in the medullary bone. So you give a full carp here pretty quickly. And we're happy afterwards. I'll give you one more example. So now this is using the QuickSleeper, but with a clear container on there. So you can put a 9 millimeter needle on this and then just manually push through the bone. Okay. I'm going to let New Smile talk about prices because it has nothing to do with me. I just want you guys to use them. The only point here is it costs a little bit more. Okay. It is a drug delivery device. It is a highly sophisticated piece of equipment. Chris, are these prices current?
Those are correct.
Okay. Yep. And there's bulk buying on things. Again, I don't have anything to do with the dollars on this. I'm going to turn this over to Chris, I think. And you want to talk through the rest of the slides here and costs and other things, Brittany?
Yeah, absolutely. So retail prices, you can see for the units there is at the top. We do offer bulk discounts for bundling multiple units. It's a 5 and a 10% discount. And then we also have university pricing, DSO, large group pricing as well.
One point that Brian Richards made to me a while ago, and I thought was very apropos, is if you already have a Sleeper 1 and SOAN and you're buying the QuickSleeper, you would already be spending, $3K or so. So it's not, an additional 10. It's really that difference of, 7 or so. But if I had one unit in my office, this is what I'd use because this, again, does everything that the other units do. Okay, tech days. Chris.
You want me to talk about this?
Why not?
Okay. So we do offer full day hands-on workshops for intraosseous anesthesia and our digital scanners that we carry as well. So we will cover the SOAN, Sleeper 1, and QuickSleeper in a full day, super in-depth hands-on course. It's a little bit of lecture in the beginning, with majority of the day spent pretty much one-on-one with a New Smile team member and or a clinical trainer or KOL like Dr. Solomon. We've had a few of these in the past already. The dates on the screen there are the remaining dates for the rest of the year. Those are held in Houston. It's super convenient. It's at the it's at the hotel attached to the airport that you fly into. So you can literally fly in, fly out. We have attendees in the past that come in that morning and they fly out that night. We go from 10 to 5-ish. So it gives you a chance to get in the morning, and then you can obviously leave at night. But I will say this was built off of attendee feedback for our previous restore and tech workshops. The ask was a full day of hands-on, super in-depth, using the devices. Attendees in the past have brought cases with them, patient x-rays, their x-rays to have the devices used on themselves. We really get into the weeds there with this, and it's a fun day.
Oops. So I want to address. Oops, that's me. What did I do? Boo. I do want to thank everyone from New Smile for bringing these devices in. This profoundly changed pediatric dentistry. It really did. So there's lots of us. There's more help than you would ever need out there. Look at all these shining faces, and I can tell you all the people that are on this screen here tonight will help you with anything New Smile. Let's address some of the questions, and I can rip through these. So number one, topical. No, I don't even know where the topical is in my office because I don't use it. You do not need topical for any three of these devices. I don't have any needles with me on, but if I did, I would just sit here and I can put 17 needles in my hands and I do not feel a thing. The needle shape is such that it is so sharp, and with that tri-level bevel, you slip it right into the soft tissue. You do not feel a thing. Okay. How much of a carpule do you, Marcy, you got lots of questions. I love it. No topical. How do you know your patient's numb? Same way that you do for a standard injection. You're going to feel soft tissue, all the normal check steps there. How much a carpule do you use? That's going to be completely dependent on what you're doing, right? I will tell you for that primary dentition, I usually never use more than a half a carp. If it's in a a teen patient or a young adult and I'm going to do 3 teeth, I typically just routinely give the entire carp that's there. Now, how long does injection take, drop by drop? What happens if the patient move when you're injecting? Well, yeah, can move when they're injecting. They can move when you're using a standard needle, right? But we should be delivering 1 milliliter a minute. Does that happen in real life with the standard syringe? No. What do people do? They shotgun it all in. And when you do that, that's where patients feel things. And that can be an issue of keeping that whole quadrant profoundly numb. So this, I think it takes what it takes. So when the thing you need to know though is once you give that intraosseous injection, you can pick up your handpiece and you're ready to roll. So the time is essentially the same. But the time savings is your patient's numb, especially that teen, and you're not going to miss a block. So I wanted to put up my information here again for all of you. I think that's all our questions, correct? So my email address, joshua@pediatricdds.com. Feel free to email me. If you email me and I don't get back to you in a day, please buzz me again. I get a lot of messages and calls and things. But I've got a QR code there with all my content information. If you ever feel like taking a hands-on course, my one little pitch here, pediatricdds.com. And they've got courses in many states. But most importantly, we are here to help you with these devices. I don't even think you need to, I could not imagine practicing pediatric dentistry without giving local anesthesia intraosseously. And now having in closing, QuickSleeper just does everything for me, right? I don't have to worry about being able to push through bone anymore. It is the Swiss Army knife of local anesthesia. And if you're not sure about things, go to Tech Day. Go to a Tech Day, fly into Houston. You can literally do it in a day. You can fly out that night without an issue, and you can perform actually injections on each other and really experience. And if you have further questions, you want to talk about these devices, reach out to New Smile. Then if they can't ask you or can't answer questions, they'll get out to one of us, those KOLs that you saw. And I just want to thank everybody for their time and attention tonight. I want to thank New Smile for providing these webinars. And if you have any interest in the new 3D printed crowns, in cements, in scanning, in printing, or space maintainers, please go to New Smile's website. There are a huge library, not only of intraosseous anesthesia, but if it is a pediatric dental procedure that is, something to do with a crown or a spacer or scanning or IO, there's a huge library and it gets added to all the time. And I just want to thank everybody for being on tonight or in the future if you're tuning in for us.